So, thanks, Gary. I'm going to bring you back to Melbourne and ask you to come on a journey with me through the looking glass. For those familiar with Alice in Wonderland, Wonderland was a bit quirky, and through the looking glass at Underworld was a bit backwards in many ways. I'd like to start by acknowledging that we're on the land of the Bunurong, Wurundjeri and Wurrung people, and pay my respects to elders past and present. I'd like to acknowledge that people have been telling stories on this land for thousands of years, and women have been giving birth on this country equally for thousands of years, and I'm going to be telling the story of birth. I'd also like to acknowledge all of you as healthcare workers and those who are doing work today so that we can be here. And I'd like to acknowledge that much of what I'm going to talk about may be triggering for some of you, including me, and more so for some of us than others. So, we're back in Melbourne, right here in fact, about a year ago. For some of us, spring 2021 was pretty traumatic, and we were looking down the barrel of a sixth lockdown. For those unfamiliar, this city was locked down 6 times. We had one of the longest lockdowns in the world. We were pretty tired by this point. I won't use the word burnout, Liz. We were tired. We had done a lot. At the same point in 2020, we were looking at around a maximum of 700 cases a day. But at that point, there was still a fair amount of energy. We were doing new things. We were working together. We were doing a lot of MacGyvering. By this time last year, looking down the barrel of Delta, we were probably all ready for some joy and a holiday, not what was to come. So I want to take you back there, and I want to kind of paint the picture as well that for many of you in the audience, you were already vaccinated. So for some of you, you were vaccinated as early as January or February, and for some healthcare workers in this city at the time, they were wondering where their booster was coming. But I'm going to talk about COVID and pregnancy, so I want to paint a picture of inequality and sexism, partly because we heard a bit of that this morning in terms of intersectionality as well. So COVID vaccine was not tested in pregnant women originally, and so there was a really big delay in the data coming out. Unusually, ATAGI, RANZCOG and the New Zealand Health Ministry released a joint statement in June of last year because they were alarmed that there was not yet access for vaccine in pregnancy. And so they released a joint statement in favour of it because the safety data was out that mRNA vaccines, Pfizer and Moderna, were safe in pregnancy. It took 8 weeks before the eligibility came. So this time last year, in September, early spring, we had very few pregnant women vaccinated. And what we were seeing from Canada and elsewhere that were about 2 weeks ahead of us in Delta was that Delta was bad news. And you're going to hear that from Anchor as well in India. Delta was bad news. People got very sick. It seemed to impact women in pregnancy more. And they got really sick at about day 9. So that's where we're at, and that's where I'm going to take you on. So, I'm an obstetrician gynaecologist. I work about 3 kilometres up the road. But this could happen, and did happen, at any organisation across this state, and I'm going to explain a couple of intricate details about Victoria Healthcare. I work at the Royal Women's Hospital. It is the oldest standalone maternity hospital in the country. It also happens to be the busiest. It was created in 1865. We moved about 12 years ago to be co-located with the Royal Melbourne Hospital. That's an adult hospital. Great, co-located. Not so great. Separated by a cafeteria named Zuki. Some of you might be familiar. We have separate health boards because there are 88 separate health boards in Victoria. Separate health boards mean we run on entirely different systems, we are entirely different staff, we have no access to each other's hospitals, we have no ID matching anything. So this is the way we communicated with each other, because we needed the obstetric team, the neonatal team, the midwifery team, the lactation consultants, our maternal fetal medicine specialists, our ID specialists who specialise just in pregnancy, all of those people from the Royal Women's Hospital to be communicating with the people at the Royal Melbourne Hospital. Because I want you to keep in mind, we're a maternity hospital primarily. We also look after newborns and other women's health stuff, but we don't look after sick patients in general. The intensive care unit and the sick patients with COVID needed to be managed at the Royal Melbourne Hospital, separated by Zuki. Or at 3 o'clock in the morning, the gates are down on Zuki, so if you need to run from the Royal Women's Hospital to the Royal Melbourne Hospital to the COVID ward where somebody is having a Metcal or a Coda with the backpack that has everything in it for a resuscitative hysterotomy or a perimortem Caesar, then you actually had to run outside the hospital, on the road, round the front, into the Royal Melbourne Hospital, and then hope to get to the right ward. So that QR code that's there, because there they've said, this patient's coming in and we're going to follow your guidelines and we're going to try and keep her with an oxygen saturation above 94%, that QR code, which is active, is not there for you. That's how we communicated with the Royal Melbourne Hospital. Because things were changing rapidly. Thankfully, we had some people on staff who are actually involved in the National Living COVID guidelines and in the perinatal component, but things were changing, and so we needed to give them a QR code so they could keep on top of our guideline, which sat on our intranet that they had no access to. Equally, if one of these patients was on the COVID ward next door and there was a Metcal or a Code Blue and they needed an obstetrician or a neonatologist, they had to call our switchboard, 8345 2222, to get our help to run over there. So with Delta, things came thick and fast, which we didn't really have in 2020. We thought we would, and we prepared as if we would. But with Delta, we just kept getting messages like this. Someone's coming in from hospital in the home. Someone's coming in from hospital in the home. So, day 9, I'm going to run you through a case of what happened. Because as we heard yesterday from Eric, there are 2 patients, sometimes more if there's twins or multiples involved, but in this case, it's a Singleton pregnancy. It's this woman's 3rd pregnancy. She's got 2 toddlers at home. They're both sick with COVID. Her partner's sick with COVID. Her parents are sick with COVID. Everyone has COVID. No one was vaccinated. It's Delta. They're all really sick. Some of them are home, some of them are at other hospitals. Day 9, 34 weeks. She's tachycardic, febrile, she's got rigors. Her oxygen saturations at home being monitored by HIF are now 91%. She's not coping. Neither would I, neither would any of you. So she comes into hospital. She's admitted to the Royal Melbourne Hospital, to the COVID ward, and she has in-reach support from the Royal Women's Hospital. Daily checks, check the fetal heart rate, check how she's going, decisions about what happens. In 2020, we thought we were going to have to deliver these patients much earlier. We waited at the women's, or at the Parkville precinct, as we call the joint area, because ideally we want to gain maturity and get to 37 weeks, which is roughly term. So 34 weeks we actually have fetal lung maturity, so it might make the decision a little bit easier if she deteriorates, but by and large we'd like to keep that baby in utero if we can. By day 11, this woman is now ventilated in ICU, and we get a call to say she isn't improving. It is now really difficult to ventilate her, and she's almost at 35 weeks. So the decision at this point is actually quite easy, because we don't want to be in a situation of an arrest where anyone is doing a resuscitative hysterotomy in ICU next door, needing us to run over, or for them to do it without us, or start without us. So the decision is made to take this woman from ICU at the Royal Melbourne Hospital to the operating theatre complex at the Royal Melbourne Hospital. And in the design sprint this morning, we've heard about the issues of geography and silos and being in unfamiliar surrounds. So whatever it is that you do in your daily profession, I want you to have a think about almost being in the field. Because for us, we were, as the obstetric team, we were in a different environment with different teams. The team at the Royal Melbourne Hospital was working with people they don't usually work with. The neonatologists were in a completely new environment. And this is what it looked like. So this is theatre at the Royal Melbourne Hospital. Again, we'd done a lot of preparation in 2020. At that point, things hadn't yet happened in terms of time-wise. By this point, they'd converted one of the theatres into a negative pressure theatre. So what you can see there is probably half the team in that theatre, which isn't particularly big. On one side, you can see the neonatal team, including a midwife who's there to support them. They've needed to bring the resuscitator from the Royal Women's and any equipment that they will need, because it is a long way to the Royal Women's Hospital to get anything, and no one's coming running in a hurry like they usually do to our theatres if something goes wrong. On this side of the curtain is the obstetric team and the scrub nurse, Ruth. Ruth works at the Royal Melbourne Hospital. Ruth was going to retire in 2020. She decided not to retire because it's a pandemic, and she wanted to stay and help her team because she got value and belonging out of that. Ruth tells me the last time I scrubbed for a caesarean section was when Jesus was born. Okay, Ruth, I've got that expectation there. So we had to open all the equipment and we had to go through everything. What do you call that? This is what we call that. This is what we do. Because there's a lot of what we call transactive memory in an obstetric team in theatre. From knife to skin, I can get a baby out in 20 seconds flat if I have to. But in order to do that, someone has to hand me things really quickly. There's no asking. It just happens. That wasn't going to happen in this theatre. On top of that, on the other side of the curtain is the anaesthetist. Now, at the Royal Women's Hospital, we're pretty spoiled. We have obstetric anaesthetists who do that pretty much all the time. That's all they do, most of them. Some of them do some other stuff. At the Royal Melbourne Hospital, they are really good at what they do. They do a lot of really amazing, really cool stuff. Transplants, trauma, general, all of it. They don't really do any obstetric stuff. They are the major trauma centre, so maybe once a year or once every 2 years they have us there doing something for a trauma patient, but not often. So on the other side of the curtain was an anaesthetist who had done some obstetric anaesthesia as a trainee, but not since then. They were really worried, what if there was a postpartum hemorrhage? They know how to manage shock, but they didn't necessarily know all the drugs. And we heard about having algorithms and checklists and the power of culture from Eve Purdy this morning in terms of we didn't have that in this team. On top of everyone you see here, there was also everybody on the other side. So there's about 20 people in this room and about 15 people on the other side, because this is a negative pressure theatre, in order to help us. And there were various ways to communicate. So you can imagine there was a decent level of adrenaline up and oxytocin down, and trying to figure out how we could make this work. So, from the session this morning, this was a relatively unprecedented event, even though we were 18 months into the pandemic. So everything actually went really well. Baby was born, baby went to the Royal Women's Hospital, to the special care nursery, and the woman went back to ICU. Only what I just told you wasn't a real case. That was a simulation. Because on top of being an obstetrician, gynaecologist and medical educator, I'm the lead of scandal simulation service at the Royal Women's Hospital, which is a translational simulation service modelled very much on the Gold Coast, and shout out to Bec Szabo, who's mentored us in that. And I want to shout out to my team and everybody at the Royal Melbourne Hospital who was involved in this work, because we effectively did do a design sprint, and with everybody who was in that room, we ripped up the guideline and we ripped up the pathways and we wrote it based on what had happened on that day. We did a lot of work to improve things based on what people found worked and what they didn't, so that it would be work as done, not work as imagined. What I'm now going to tell you really happened, because genuinely a week later, on a day off when I was at home, I got a message on the WhatsApp, Bec, there's been a Metcal on the COVID ward and we need you to come now. There is a patient who urgently needs to go to theatre for a Caesar. Some of what I'm going to tell you is an amalgamation of cases to maintain confidentiality and privacy. So let's say this is a woman who's in her second pregnancy. She's 33 weeks, so just under that gestation. She's now day 10, bit the same, everybody's got COVID. She actually comes from a rural regional area and has needed to come into the precinct so that there's access to special care nursery and neonatology. She was admitted 24 hours earlier because she wasn't coping at home, as very similar, fevers, rigors, unwell, low oxygen sats in the low 90s, and overnight she's desaturated and she's not doing well at all, and she was near peri-arrest. They were pretty close to calling code blue. So they've called a Metcal. So Lauren and I go in. Lauren's had to call the second on call to take over birth centre because she was the one on, and we let everybody know we're going across to the Royal Melbourne Hospital. This is a real case. This isn't the simulation work that we've been doing. The woman's going to go to ICU afterwards and the baby's going to go to the Royal Women's. We get there and oh my God, 80% of the team had been involved in the simulation work. Did we feel good? Oh my God, we've got this. This is amazing. Ruth was there. Legitimately. Oxytocin levels up, adrenaline levels down. Everything was fine. We had been told the patient had the Metcal, they'd intubated her on the ward, they were going to bring her around, then she was going to ICU. I mean, we'd done this exact scenario, right? With 80% of this team. We knew exactly what we had to do. We were technically ready. But I'm going to take you through the looking glass. One can't believe impossible things. We hadn't simulated for what happened next. Preparation is important, but we can't prepare for everything. Or perhaps we need to think about everything to prepare for. So into the room, all of us in our PPE, all of us ready because we thought she was already intubated, came a woman who was sitting bolt upright with a respiratory rate close to 30. She was awake. She was not intubated. She was using all her accessory muscles. Her lips weren't just blue, they were purple. It had been a really long time since I had seen an adult patient in front of me who looked that close to death. She was holding her pregnant belly in front of her and her eyes were pleading with us. She looked terrified. Here were two patients who we needed to save, a mother and a baby. There was no partner, there was no support person, there was just her with her purple lips and her pregnant belly. And I can tell you at that moment, all our feelings of we've got this, we've prepared for this, this is great, disappeared. As if someone had opened the negative pressure door. And the adrenaline went right up and the oxytocin disappeared. Until the neonatologist walked from where the resuscitator was over to her, put his hand on her shoulder and said, "Does your baby have a name?" That human moment, that connection, for those of us in obstetrics, the most normal thing to do at the time of a caesarean section, it was like we all exhaled collectively. I don't think the oxytocin in the room ever quite went back to where it was, because the seriousness became very real, the humanness became very real, but the adrenaline level certainly went down. And we were able to proceed, and she was intubated, and thankfully the case went completely smoothly and uncomplicated, and the baby went to the Royal Women's Hospital nursery, and she went to ICU, and then they were reunited about a week later. She did very well. So as I said, we can prepare, but we can't necessarily prepare for everything because we work in complex and complicated environments with things that are unpredictable and uncertain. Teamwork and communication are everything. But being with women, like my midwifery colleagues, listening to the voice of the patient is absolutely vital. We've heard that belonging and community and connection are so important, and having those values and shared goals to keep us doing what we're doing. This was technically straightforward but emotionally fraught, but I would do it again. And I think we need to remember that we are indeed the captains of our soul and of others, and we are not robots, we are human. And if we can be human and kind, then we can deal with these emotionally fraught situations. Thank you.